So thank you so much for this. And I think, is there another question, Tanya? Do we miss anything? And if not, we should go straight to the Mosaicism.
So one last question is this a replacement to testing in pregnancy? So you are now pregnant with a PGT healthy embryo and you're 11 weeks. Would you do all the standard testing of the baby? So tell us about that.
Yeah, we still recommend that. There is probably about a 1 to 2% error rate. And part of it is mosaicism, part of it may be error. And so because we are, again, taking the cells from the part of the embryo that would become the placenta. So sometimes the fetus isn't the same as the placenta. And so we do encourage our patients to also get NIPT, non-invasive prenatal testing, and our partnered OBGYNs, we say, no, just because they had their embryos tested doesn't mean they shouldn't have any prenatal testing. So absolutely, they should have that.
A little more confidence going in though for that testing. You're less stressed out, which helps, having done the PGT, doing those prenatal testing.
If you've done both of them, that's great. Yeah. There is
awesome.
One other thing that you might just want to mention, Mary, is that we are hoping in the next 5 years to move to a more non-invasive method to test for chromosomes. And so the two ways that we're hoping to do that is if an embryo is cultured in media, to take the cells that are shed from that embryo and to test those for chromosomes, or to take some of the fluid that's on the inside of the blastocyst and to test those. So that's basically sort of non-invasive PGTA.
Right.
And there's a lot of kinks that still have to be worked out with this, but any concerns folks had about biopsying embryos or might be overcome by trying to get results in a less invasive way.
I love
Once
that.
the technology is there. Yeah, it's great. It's a brilliant idea. Yeah.
It's a patient question I get a lot. Like, what if there's damage and that's why my PGT
right.
embryo didn't transfer? And so then, it kind of takes that factor away.
Yeah, even us as physicians, our embryologists are like, they are so hardy. And we're like, oh yeah, but you're doing this and this and this to the embryo. But they do seem to do quite well. So, and all of the studies so far that have looked at outcomes after doing PGTA with blastocysts, with the trophectoderm biopsies have been encouraging in terms of outcomes.
Awesome.
Well, thank you. Okay. So I hope that decreases stress rather than raise stress, because sometimes more information causes confusion.
No kidding.
Lots of acronyms going on.
Absolutely.
Right? Mm-hmm. So if there's any concerns, feel free to reach out to us. And then now let's it's not actually, it's the same thing, but deeper dive into Mosaicism, which we mentioned earlier. So let's begin that conversation. And I'm so excited that Dr. Laurie Marshall has actually done research on this. So let's go straight into it.
Yeah, what is it first, maybe?
Thank you so much for inviting me. This is a sticky topic, and hopefully I can explain it clearly to everyone. And we struggle with it every day. Basically, what mosaicism is in general the presence of more than one distinct cell line in a sample from an individual, from a person. Right. So, and some of you have heard, so you can see there, for example, there's a mosaic Down syndrome. So there are individuals who have Down syndrome, but they have some cells that are Down syndrome and some that are normal. And usually in those cases, they're not as severely affected as if they were full chromosome Down syndrome. Right. So
you know what, before you go on, if you don't mind, we're just going to rehash exactly what that means. So when we biopsy some cells, and it's more than one, right? So you can have multiple cells, and some of them are tested as normal chromosomally, and others may actually say, oh, there's Down syndrome cells here. right?
Yes,
So
yes.
that's what mosaicism is. So
That's-
it's not
so-
all the cells have it.
So technically you're talking about an individual, right? But we go back to embryos and we can look at embryos that have a mixture of normal and abnormal cells. So, so if you look at a blastocyst and it has an outer portion to it that we call the trophectoderm, and that those cells become the placenta, and there's a portion that is the inner cell mass that becomes the fetus, and those can be all normal, and we call that a euploid embryo. They can be all abnormal, and we call that an aneuploid embryo, or it can be a mixture of both. And so the mixture could be that the cells are normal in the inner cell mass, which is the portion that becomes the baby, and abnormal in the placenta, which is a portion that becomes, or in the trophectoderm, which becomes the placenta, or the normal and abnormal cells could be scattered throughout the embryo. So this is the bane of our existence, right? This is so difficult for us because when we're testing embryos, we want a normal, abnormal result. We don't want anything in between. And so this challenges us a lot because, of course, we don't want to transfer an embryo to a patient that would result in an abnormal child. The truth of the matter is, although I used an example of a mosaic child, there aren't that many mosaic individuals. And so really with IVF, we're not trying to prevent mosaicism. We're trying to just get our patients pregnant with healthy children. And mosaicism isn't really something that we've thought about much in the past until we now have such sophisticated testing of embryos that we can see these in-between results. So it took a lot of courage, I think, for clinicians to say, well, you know, maybe some of these mosaic embryos can become babies. And particularly if not many of the cells are abnormal. And so, so we have over the past 5 years gently put our toes in the water and tried to start transferring some of these embryos to see what the outcomes would be. There have been probably reported in the literature maybe 1,000 or more transfers of embryos that have these in-between results, and the outcomes have been surprisingly good, so that we have learned that not every mosaic embryo is the same, and we have gradually learned which ones might be preferential to transfer.
And that's great. And, you know, we certainly see that as well. And the people will ask, oh gosh, like I just have one embryo in the bank and it's mosaic. What do I do? Do I go ahead or do I do another IVF, right? So how do you speak to someone about that?
So still, I think if there's somebody who is in an age group where they could still produce eggs, could still make embryos and have either insurance or can afford to do another IVF cycle, I think the preferential approach is to do another IVF cycle and to try to get embryos that are clearly in the normal range. They're probably the bulk of the data together suggests that pregnancy rates aren't as high if you transfer an embryo that's mosaic, even if there are just a few cells that are abnormal, and miscarriage rates are probably higher. And so it's kind of a second tier embryo. So particularly if you're hoping to have more than one child or whatever, you should probably do another cycle and preferentially transfer a full euploid embryo. We basically have evolved, like as we're learning more, we're trying to all of the clinics are trying to evolve our policies and guidelines in terms of how to handle these. And we have done the same. Initially, when labs started reporting mosaic embryos a couple years ago, we said, oh my gosh, we can't transfer those because we don't know anything about transferring them. We don't know if we're putting patients at risk of having an abnormal child. We don't know what the pregnancy rates are. So we did not transfer any mosaic embryos at first. And then with time and with a little bit more data, we decided to get our own data. And we have a wonderful genetic counselor who spends an enormous amount of time with our patients, counseling them about mosaic embryos and the unknown risks that they might take. And so we have, over the past year or two, been transferring selected mosaic embryos and have had good success rates. We carefully choose the ones where there are low percentages of abnormal cells. A normal embryo has less than 30% abnormal cells. An abnormal embryo has more than 70% abnormal cells. A mosaic embryo in our laboratory, and pretty close to this in most laboratories, have 30 to 70% of their cells are going to be abnormal. So, and when we get a report from the lab, it tells us which percentage of cells are abnormal for the chromosome that's affected. So if, say, it's chromosome, 16 or whatever, it will say there in 35% of the cells, there is an extra chromosome, 16. And then that is an embryo that we might consider transferring before one that has 65% of the cells are abnormal, because it's more likely that that embryo is not going to make it any further in culture, and it's more likely that it actually truly is an abnormal embryo.
That's fascinating. I didn't realize that for healthy embryos that they had a percentage that were actually considered to be okay to be transferred in abnormal.
Well, there's a sensitivity of the assay. So anytime you test anything, there's like we say, gee, this test can't pick up, can't say with a great deal of reassurance that there's going to be less than 20%, right? So they have a cutoff. And so it used to be with the older methods of testing that weren't as good as what we have now, that they had a little higher cutoffs. So probably, 30% or so was the cutoff. And then anything above that, we just called abnormal, right? And so now with mosaicism, you can look at it two ways. You can look at it as a huge headache, right, for doctors and for patients, or you can say we are now offering the opportunity to transfer some of these intermediate embryos, and a certain percentage of those could become babies. And not first choice, but second tier, right? Second choice.
Even the normal ones, to be more specific, even the normal ones do have a percentage. I just find
even normal ones have a percentage of abnormal cells.
Yeah, exactly. So it's kind of like they're all mosaic. It's just like a range.
Yes.
Okay.
The embryos in development are far more chaotic than most of us realize,
Sure.
right?
Right.
So and there's certain stages. That's why day 3 testing was so awful, because that's one of the most chaotic times for an embryo. And by the blastocyst stage, the embryo has settled more into its chromosomal makeup, but it still has work to do, right? So and we don't totally understand what happens. It's research on an embryo from like day 7 to day 14 is really restricted, right? So It's hard for us to learn that. But what we think may happen, and from some work in Belgium, is that if you culture that embryo like a mosaic embryo out to day 14 in a laboratory with special permission, that the ones that are low-level mosaics will either make it to day 14, and if you retest them, they're normal, or they'll die along the way. The higher level mosaics, which means closer to 70% abnormal cells, it's less likely that they'll make it out to day 14. They usually just die on the way out. But all mosaic embryos in the study from Belgium, if they made it to day 14, they were normal. So they do probably repair themselves to a certain extent, or the fetus, the embryo kind of throws the abnormal cells into the placenta. And then the fetus may be normal.
So going back to, for those people that are joining in, we just want to refer back to the previous interview, which is about the genetic testing in general. And we were addressing also how not all chromosomally normal embryos are babies. So you just basically spoke to that, which is great. And so, and then going back, we need to actually introduce you again, because for this portion of it, some people may be just joining in. And Dr. Laurie Marshall is from the Pacific Northwest Fertility Clinic in Seattle. And she is, I'm so proud to hear this, by the way, that you are the first fertility doctor, a female fertility doctor in Washington. And not only are you a fertility doctor and reproductive endocrinologist, but you're also an OBGYN. And I love it that you're a professor and researcher, as well as a professional, a doctor seeing patients. But what I love most is that you're also an advocate who is currently supporting a movement to pass legislation to require insurance coverage to help build families in the state of Washington. So, thank you, kudos to you. Obviously, it shows that you are dedicated and you are there for people building their families. So thank you.
Thank you for inviting me on your show. I really appreciate it.
Oh gosh, people need to learn about this. And I certainly taken away some stuff here. So we can go back to our patients and give them more information as well, and to not confuse, but really to have informed choice and decisions around, do we really want to do genetic testing? And then secondly, if we have mosaicism, do we transfer that and have them be informed so they can self-advocate, right?
Right.
So in terms of the study, because you were taking your own data, do you have much or specific numbers for us regarding normal embryos being transferred, making it to babies versus the mosaic embryos that you've transferred for women? Do you have stats on that you can report?
We do. So we have gradually started to transfer mosaic embryos, and our live birth and ongoing pregnancy rate has been 53% in women who
Wow.
Mosaic embryos transferred, and that's lower than screened embryos and higher than unscreened embryos. So if the embryos are screened, it's about 70%, 69 to 70% in our clinic. And if you don't screen embryos at all, it's various age groups, and it would be lower than that 53%, in the range of 30 to 40%, depending on the age of the woman. So it is encouraging. I would say that we spent a lot of time picking the patients that would have mosaic embryos transferred and picking the embryos that they transferred. For example, almost all of those patients that conceived had low-level mosaics, or what we call segmental mosaicism. When you do PGTA, you look for an extra chromosome, a missing chromosome, but we also look for a big chunk out of a chromosome, which we call a deletion, or a little bit extra chromosomal material, which we call a duplication. And they're less common than the trisomies, which is an extra chromosome, or monosomies, which is a missing chromosome. And they probably aren't as I don't know what the word is. So they probably don't affect the fetal development as much as what we call a whole chromosomal abnormality. So, so most of the pregnancies that we had with transfer mosaic embryos were the low-level mosaics, sort of 30 to 50% of the chromosomes had one abnormal chromosome, or they were deletions or duplications that were mosaic. We did not do well with high-level mosaics, so when there were 60% or 70%. But we also say if a patient had more than one mosaic embryo, we would advise them to transfer a low-level mosaic first. And that may be partly why our success rates are as high as they are, because we are carefully trying to choose the mosaic embryos that are the best to transfer. So some of the success rates in the early papers were much less than that, but they were also learning which mosaic embryos were the best to transfer.
Of course, that makes so much sense. That's, again, very enlightening. And I remember what you said in the first portion of the podcast, where you mentioned that, it doesn't matter your age. Once you've tested and it's whatever the chromosomes are, if it's normal, then it's irrelevant of age, correct? Am I saying it right?
Right, pretty much. Yeah, it's just a teeny bit less for a 41 to 42-year-old age group, but it's like 61 to 62% and high 60s to 70s for our younger patients, but very close to the same. And that actually surprised us, because we thought there was more that age did to an embryo than just, affect the number of chromosomes. So if you are older and you can find that, that normal embryo, that success rates are still good. I think one of the surprising things for us too, looking at mosaicism, is that we know aneuploid embryos or abnormal embryos are much more common as women get older. And so you see an increase in the percentage of abnormal embryos as women get older. You see a decrease in the number of normal embryos as women get older. But mosaicism we see in all age groups. And it does vary a little bit, but you see as high a percentage of mosaic embryos in our younger patients as our older patients. And when we looked at our data, 42% of our cycles had at least one full chromosome mosaic embryo. So this is not a small problem. This is not something that just, happens every once in a while. And in many of our younger patients, they also have enough normal embryos that they don't really have to deal with the question of mosaicism. But we say, hey, hold on to those embryos, but don't use them first. You want to use the ones that are definitely normal first. But a lot of these young women who have good egg supplies, even egg donors, have mosaic embryos. And it may be that they're closer to normal. Some of these are closer to normal. And so because they have more normal embryos, they have more of these closer to normal embryos. But we don't really have a good handle on why it's not age dependent, really.
I love that. And that's something new. I did not know that there were lots of mosaic embryos for the younger population, especially the donors. So that's really insightful. And I guess when you talk about low level versus high level mosaicism, and just to be clear and to reiterate, in terms of low level now specifically, does that mean it's like just one chromosome that is wrong, and it may only be like, let's say they are biopsying 10 cells and out of that, 2 are abnormal, and it's the specific chromosome for Down syndrome that is the issue? Like, I want to have clarity for people exactly what that means.
Mm-hmm. That's not exactly how the results come out, but that's basically a good way to think of it. and usually we don't take quite 10 cells away from an embryo. We might take 5, but so yes. So low level means, yes, a lower percentage of the cells show the abnormality. And so we think then that it's more representative of the embryo. If a higher percentage of the cells are abnormal, that's more representative of an abnormal embryo. But the other question that you asked is a good one too, which is that sometimes we do see 2 chromosomes that are mosaic. And in our experience and in the experience of others, success rates are not as good when 2 chromosomes are reported as being mosaic. Even if they're low-level mosaicism, we haven't seen pregnancies in that group. Others have seen some pregnancies, but at a much lower rate. So we certainly would prefer to put in our low-level deletions, duplications, whole chromosome abnormalities first. Second is probably the high-level deletions and duplications, and then and then really, tied for last place would be 2 chromosomes affected or a high-level whole chromosome mosaicism, which means a full extra chromosome or a full missing chromosome. So we do tier that, and our genetic counselors are very careful about that. Initially, there was like, oh, if there's an extra one, it's worse than if there's a missing one, or they went through all of this. But this is pretty much how we're looking at it now. The low-level mosaics are the first ones we transfer. The last ones are when 2 chromosomes are affected.
Wow, this is awesome.
Yeah.
Lots to think about for sure. And I know it's come, we could just talk about it for a whole day, but
yeah,
we're all busy and we have to run off and do our thing. And there's so many things, variables, and, life is a miracle, period, right? And to add all this to it, it's complicated.
I think it brings hope to mosaic embryos. And I think it gives me definitely an understanding that, if the normal embryos have a little bit of abnormal, then it's just all in a spectrum, and the technology is just going to get better and better over time, which is very exciting. So thank you so much for sharing, Dr.
Yes. And I think we're moving to the point where we hope people understand we're just trying to select the best embryo. So we'll pick the ones that are completely euploid first, and then we go down this list. And if you just have embryos that are down the list a bit, we don't necessarily toss those, but we can maybe give them a chance, although they wouldn't necessarily be the first pick if we had a lot of embryos to choose from.
And it also gives us an answer to that question too, like why is it that some of the PGT healthy embryos don't take? Just because, right?
Exactly. It is one of the reasons, probably. Yeah. And I think the other piece of this is that from what we see is that when there are live births, those children seem to be normal. There was one reported case where they detected mosaicism in the offspring when the embryo was deemed to be mosaic that was placed in the uterus, but the baby was fine, right? And at this point, a lot of the studies that we have not actually done genetic testing on the babies that have been born. The parents have to agree to it. And frankly speaking, a lot of folks that have put in mosaic embryos are like done with genetic testing because they feel like they've got just confusing results and like, why do more tests? Just give me a normal baby and I'll go with that, right? So we still have a need for more data on the children that are born after the transfer of mosaic embryos and maybe the placentas. And no one's really been testing the placentas, but it's an interesting thing that we think some of these cells, abnormal cells, go into the placenta, and it'd be interesting for us to see if that's where we're going to find the abnormal cells.
Wow, this is awesome. This has been so enlightening and enriching, and I hope that everyone that's participating in this conversation gets a lot out of it, and then that it really does help you decide what to do in your journey when it comes to IVF. And certainly go check out both of the podcasts. So this one, and then, by the time this is out, we will definitely have our My Fertology website up and running. And there are other pre-recorded podcasts there already to serve you in your life. We look at all the pillars of your health as well. Do you have anything else to add, Tanya, about that?
I guess the biggest thing, just in relation to this episode, is that Dr. Laura Shaheen works with Dr. Laurie in Seattle. And one of the episodes that we recorded was on giving hope to women with PCOS. And among so many episodes that we've recorded on all the years, women from preconception will be talking about through pregnancy, because it doesn't just end in fertility. Women who have struggled to get pregnant, there's still a huge journey of life ahead. And so we want to address that through our upcoming podcasts as well. So thank you so much for joining us. And thank you to everybody who's listening. And please share this, because there are so many people with, going through this journey right now and who don't have answers. And I feel like this episode answered a ton of questions that I had. And people will be so happy to understand it a lot more thoroughly. So thank you so much, Dr. Laurie.
Yeah, and I'm so excited. Yeah, thank you so much. And you know what? We have to also announce this. We are super excited, because coming up soon, we're also going to be starting an actual program where we can mentor you through your fertility process. Because, although Dr. Tanya Wylde is the naturopathic doctor and I'm a acupuncturist and traditional Chinese medicine practitioner, it's much more than, either sticking a needle in or doing IVF or taking a supplement. It's about your life and your well-being while you're going through it. And we are going to hold your hand through the whole thing to make this process way easier. So we're super excited to be able to promote and share the live webinars that we're going to have in the future. So thank you. And so thank you again, Dr. Marshall, for being here. We are so super thrilled. And you've just shed amazing light to this conversation, which everyone, I literally say every single woman and couple are always a little confused about, the genetic testing. So you really demystified it. Thank you.
Great. Well, thank you so much for inviting me. It was a pleasure.